Good evening to all. Today I will be talking on a topic which is for us more important for us clinicians with what we see in our day-to-day practice. I will mainly talk about the gaps in our guideline and what are the modifications we need to do in specific patients like this. So this is just a prototype patient like we see in our day-to-day practice, like a 68-year-old male, non-diabetic patient, currently on basal insulin along with oral anti-diabetic agent, known patient of CKD, and patient already had an PTCA maybe 2 to 3 years back. With the past recent history, patient is having mild fever with lethargy and a little bit of nausea and persistent vomiting for last 3 to 4 days. And as the patient was not being able to eat, and patient himself has discontinued the insulin. Now came to our emergency with the shortness of breath and pain abdomen. So with this in the background in the ear, so they did the basic evaluation of the patient. The patient is already having pedal edema, heart rate may be around 110 with the BP of 140 by 70 and a saturation of dispute of 88. The neck bones are involved, chest waves are there. And in labs, the CBG is 386. ABG, there is evidence of metabolic acidosis with an anion gap of 24, potassium is 4.9. Creat, we get a little bit later with an 4.5, uncontrolled hyperglycemia, A1C of 11.3. Urine examination, albumin plus, ketone body 2 plus with a partial of around 10 to 12. The point of care, the echo screening revealed an EF of 35% with no recent So with this background, so what can be our working diagnosis and how we are going to manage this patient? So this type of patient is not very rare in our clinical practice, and we all know we have a set guideline for diabetic ketoacidosis set by different authorities like British Diabetic Guideline. Also we have a combined guideline from ADA. However, we cannot manage this patient if we go by the guideline in detail. So what are the modifications we need in our patient, specifically if this patient is having this situation that is my agenda for today's talk, like in comorbidities like the patient with CKD or heart failure or acute coronary syndrome as Sarah suggested, or the patient with pancreatitis, in special population which needs special care like our geriatric population or in pregnant patient. And now we are seeing different atypical presentation of decay also, like with the use of SGLT inhibitor, the risk of glycemic decay and also the overlap of decay and hyperosmolar state. So decay in chronic kidney disease like in this patient, so almost 7.5% of the patient we get admitted in decay, they are having end-stage renal disease, and this patient they have a higher rate of complications like increase in the hospital stay, higher readmission rate, increase in the mortality as well as increase in the hypoglycemic rate. The problem of this patient is that from the presentation point of view also, that this nausea, vomiting, acidic breathing, sometimes we think it is because of renal failure per se rather than the decay. And the classical features of decay like dehydration is sometimes absent because there is a lack of osmotic diuresis in the patient of CKD, and that's why dehydration or volume depletion is not common. Perhaps they can present with hypervolumia. This patient has higher risk of hyperkalemia because of there is again lower renal function as well as the persistent metabolic acidosis. They have a higher glucose level, hyponatremia and hypophosphatemia. So if you look from the basic diagnosis point of view, we mainly rely on these 3 parameters for the diagnosis of decay. One is hyperglycemia, one is ketosis and one is metabolic acidosis. Now for the CKD patient, the hyperglycemia sometimes we can miss because in most of the CKD patient now, specifically in diabetic patient, we use SGLT inhibitor which can lead to glycemic decay. So we need to be cautious. Metabolic acidosis, whatever we find in our patient, that can be due to pre-existing metabolic acidosis because of the renal failure per se, because both of these will cause high amount of metabolic acidosis. And ketosis sometimes, like in this patient, may be due to prolonged fasting or maybe due to repeated vomiting or because of the use of drugs. So in this background, that's why it's very difficult in our day-to-day clinical practice to give a pinpoint diagnosis. However, if you look in the literature, most diagnosis of decay in the background of CKD, if the NRW is a little bit higher, like it is more than 20 milliequivalent per liter, or after therapy, like retrospectively, if the fall of NRW after insulin therapy is more than 5 milliequivalent per liter. Or another thing that is very important, that we measure the serum, that blood ketones, mainly the beta hydroxybutyrate. If it is high, more than 3, then mostly we consider this is a patient of decay in the background of CKD. And we need to deviate from the standard set guideline in this group of patient, because in case of euphonic CKD, as there is lack of dehydration, we do not recommend that initial bolus as we recommend in the standard guideline management for decay. And if we need a very strict and continuous hemodynamic monitoring of the patient, if we found the patient to be hypovolemic only, then only the IV fluid is given in a small aliquot of around 250 ml per time, and it has to be given slowly. The standard insulin infusion rate, like that a fixed rate IV insulin therapy that we give in decay patient, that has to be also reduced to around rate of around 0.05 unit per kg per hour, rather than the standard dose, specifically those patients who are already in A30, or in those patients having low glucose of less than 250, or if the fall of glucose is more than 50 mg per dl per hour. Routine supplementation of potassium is not recommended, and normally we do not give bicarb whenever you are managing any decay patient, unless the patient is hemodynamically very unstable and the pH is less than 6.9. But however, in some of the guidelines they have recommended, or they have said that it can be used in case of pre-existing chronic metabolic acidosis due to renal dysfunction if the pH is less than 7.2, only in this background. Now, decay in heart disease is another area where we have to be very cautious, because we all know that diabetes per se will increase the risk of different heart-related conditions, mainly the acute coronary syndrome as well as the heart failure. For decay and ACS, which causes which, it is very difficult to diagnose. So it is a classical example of chicken and egg conundrum. And sometimes the classical symptoms of diabetes is missed in heart failure patient because of the use of diuretics, and this coexistence of a heart failure and diabetes is very difficult to diagnose clinically, because there is a paradoxical intravascular volume depletion along with peripheral edema, and decay per se can increase the cardiac enzymes, mainly the troponin. So these are, for these overlapping reasons, it is very difficult sometimes to get a pinpoint diagnosis. Again, for treatment purpose, this decay with heart failure, it is we need to balance the fluid management very carefully, because there are two fundamentally opposing management protocols. In one side, decay wants this aggressive fluid management; on the other side, we usually restrict fluid for the heart failure. So that's why an invasive hemodynamic monitoring like that IVC and arterial line sometimes we need for the proper intravascular volume status, and very cautious and sole replacement of minimal fluid bolus is needed in this patient. And sometimes, if the patient is the BP, the blood pressure is low, it is not because of intravascular volume depletion, but because of the heart failure per se, and we need vasoactive agent rather than IV fluid for managing this patient. And hypervolemic patient, those who are having low glucose, we need to sometimes use concentrated glucose like 25 mg rather than 5 mg or 10 mg, just to reduce the volume load in this patient. We should not forget to find the precipitating cause like infection, diarrhea, stress, which can precipitate a cardiac event as well as decay in this patient, and we need to modify the chronic medication, specifically SGLT inhibitor, if used in this group of patients. Another area like though a little bit less common, however, that need to into drastic consequences. However, treatment-wise, a little bit is the protocol-wise, the treatment usually doesn't differ, and we need the RD fluid replacement and concurrent management of acute pancreatitis. Use of IV insulin is helpful to further rapidly reduce the increased triglyceride level in this group of patients. So these are the common comorbid conditions where we need modification for the management of decay. Coming to the special population like in elderly or geriatric patient, again the management is difficult because in geriatric patient there will be multiple comorbidities like CKD, heart failure, and the increased risk of in-hospital mortality, prolonged hospital stay will be more in this group of patient. Another problem is that with the geriatric patient is that they are relatively asymptomatic. The presentation for decay sometimes can be simple neurological presentation rather than a GI symptoms, and sometimes the precipitating factor, precipitating cause like an infection, sepsis may be remain unnoticed because of the marked features. There can be sepsis without fever, so that's why our clinical eye should be very wide open so that we do not miss the precipitating factor.